Okay, ready? Those who were sleeping till now, please wake up. We are going to study cardiovascular system. Very, very important for your paper two. Cardiovascular system, entirely conceptual. Entirely conceptual. You cannot afford to fall asleep. Will we start? How many of you are ready? Raise your hands. Cardiovascular system. Okay, let's start with our this thing, Parampara Pratishta Anushasan. That is our template. What is the template? How many of you want template? Or should we directly go with the table? We need a template. Okay, let's do that. See, the common definitions are, you have to first define whether it is a condition or a syndrome. So I'll tell you an example in the definition one part. All of your valvular disorders are a condition, right? So whether you talk about your MR, your MS, your AR, your AS, all of them are a condition, right? But whereas we have this syndrome. So what are the syndromes? Your heart failure is a syndrome. You have this ARF, infective endocarditis, and acute rheumatic fever. All of these are the syndromes. So you first tell whether it is a condition, a degenerative condition, or any syndrome, any specific syndrome. Is it a part of that syndrome? Okay, so that's what you need to tell in the definition. Is it a condition or a syndrome? Okay, so that's what you know. What about the causes? Common causes for everything in here is, you have to classify whether they are the primary reasons or the secondary reasons. Primary means most likely it will be degenerative. Most likely, all of your valvular heart disorders, if you write the word primary, most likely, for example, you take a case of MR. Why most likely MR happens? Because of degeneration. So MR must be preceded by something known as prolapse. Okay, before it regurgitates, before the valve fails, first the valve prolapse, then the valve, complete failure happens. We call it as regurgitation. Okay, so primary reasons could be a degeneration. Okay, secondary could be, some specific organisms. It can be some specific organisms. So if it is for the infective endocarditis, mention that specific organisms. Or secondary reasons could be the autoimmune conditions that we will talk about this. So mention the causes under these two headings. Your causes for cardiovascular system is incomplete if you don't mention the risk factors. The common risk factors, like what? What are the common risk factors? Can somebody tell me? Common risk factors. What do we have as a common risk factor? People. Those who are not sleeping. Risk factors. Common risk factors. Hypertension. Okay. Okay. Atherosclerosis. Obesity. Smoking. What else? You modify them into modifiable and non-modifiable. Okay. Modifiable means what? All of your lifestyle related conditions that you just talked about. So we have smoking. I can modify it, right? I have abnormal lipid profile, your hyperlipidemia. I can get rid of that hyperlipidemia. I have hyperglycemia, that is your DM. I have hypertension. So all of these hypervalue conditions I can get rid of, right? So these are the modifiable factors. What is non-modifiable factors? I cannot change the gender. Like nowadays we can change that also, but you remember the male gender. Non-modifiable factors, male gender, increasing age, that is your elderly, are non-modifiable. Any genetic predisposition, if I have some HLA mutations, those are non-modifiable, and my family history is non-modifiable. Any family history of MI significantly increases your risk for carbo with this. In non-modifiable factors, may you also remember, we have this CRP, hyperhomocystinemia. So these are some of the risk factors that you need to mention in almost every answer of cardiovascular system. Followed, everyone? So these are about the risk factors. What will you write under the pathogenesis? Pathogenesis may, even if you don't know anything, just give a brief overview. Meaning, right, there are how many chambers in the heart? You have 4 chambers in the heart. So we have this right atrium, right ventricle. We have left atrium and left ventricle. So what is the valve between this right atrium and right ventricle? Okay, the valve here is tricuspid valve. What is the valve between the left atrium and the left ventricle? What is the valve? Mitral valve. Okay, so you just need to know about this. After that, right, from the right ventricle, what is leaving? Leaving. You have pulmonary aorta, which is leaving. So this is pulmonary aorta. which in turn give rise to two branches. Those are pulmonary arteries. So this is pulmonary aorta with pulmonary valve. So pulmonary valve will be there. Then what else we have? Left ventricle, say it remove. What is happening? Systemic aorta is leaving. Systemic aorta that we commonly refer to as aorta, and it also have this bicuspid semilunar valves. So we have an aortic valve. Okay, aortic valve. Now, if they give you MR, or if they give you MS, or if they give you AR, or if they give you AS, you know what should happen, right? So you tell from normal flow of the heart. How is the normal blood flow? First of all, you need to know that inferior vena cava will bring the blood from lower part of the body to your right atrium. Superior vena cava will bring the blood from upper part of the body to your right atrium. So now the blood will be in the right atrium. From the right atrium, the blood goes to the right ventricle. From the right ventricle, the blood will be pushed out in the systole to your pulmonary aorta. So from pulmonary aorta, blood will get oxygenation in the lungs. Okay. So this is pulmonary circulation. So blood will get oxygenated in the lungs, and from this is connected to the lungs, and from the lungs we have the four pulmonary veins. We have the four pulmonary veins that brings back. So how many pulmonary veins? Four pulmonary veins. So two superior, two inferior. So they bring the blood back to your left atrium. So this is how the blood flow, normal blood flow will happen. From the left atrium, the blood will flow via the mitral valve to your left ventricle. From the left ventricle, the blood will flow to all of the body tissues via systemic aorta. Followed, everyone? So this is important. This normal flow is important, and you can use this normal flow to to talk about the pathogenesis in any case. Okay, what should happen in a stenosis? So in a stenosis, mitral valve is closed, like not opening properly. Then what is happening in MR? MR is mitral valve does not close. Okay, meaning keep open. Okay, so it is open. Mitral valve is open. So now, you can just use logic and tell me what should happen in stenosis. In stenosis, this will be affected if mitral stenosis is there. The right flow side will not be affected. So right side will everything be normal. But the problem is when your pulmonary veins, what is this? Pulmonary veins. So let's write that. Pulmonary veins. So when pulmonary veins bring the blood to your left atrium, what should happen? The left atrium should contract and should push the blood via the mitral valve to left ventricle. But if stenosis is there, then this blood cannot flow because mitral valve is closed. So what will happen eventually? Left atrial hypertrophy, or can I say, this does not happen. So this cardiac output ka problem will be there. So just use logic and elaborate on the pathogenesis. Okay, so the same you can do for the AR and AS also. What will happen in AS, atrial, aortic stenosis? Aortic stenosis means left ventricle tries to push the blood, but it cannot push the blood. Okay, why? Because this is closed. Okay, so you see a lot of murmurs here. So some murmur will be there. So in pathogenesis, you mention. So first mention the normal thing in pathogenesis. So you talk about the normal thing. Then talk about whatever the disease state is there, उसकी pathology. What should happen? The exactly opposite should happen there. Followed, everyone, regarding the pathogenesis, the common pathogenesis. How many of you followed? Please raise your hands. Pathogenesis wala part. Okay. Yeah. So this was about the pathogenesis. Now let's talk about clinical presentation. See, a definition is nothing, Baba. You have to first tell whether it is in any condition of the valve or any some specific syndromes. Okay? All of your essay questions can be described under these two headings: any valve condition or any syndromic association. So like your heart failure, infective endocarditis, and acute rheumatic fever, they are the syndromes. Like they are not a particular disease; they are a cluster of disorders. So that is about the definition. So now what will happen in the clinical presentation? So in clinical presentation, as we always write, you also mention this in two headings: the symptoms and the signs. Can somebody tell me the common symptoms of any heart disease? Common symptoms. Yes. Can you write chest pain at least? You can. What else? Dyspnea. Difficulty in breathing. Dyspnea. Can I also write fatigue because heart is not pumping? Fatigue. Can I write palpitations? Right? So you can write that also, palpitations. So these are the common things. Common things. Okay, common symptoms. What are the signs? Signs in the people. Can I write edema? If heart is not pumping, especially in heart failure, you can write edema also. What else can you write? Any murmur, any specific murmur. We'll talk about murmurs, people. So at least you know, is it a systolic murmur or is it a diastolic murmur? Okay. Systolic or diastolic, that must you need to write. Even if you cannot write the specific murmur, at least to know whether it is systolic murmur or a diastolic murmur or a continuous murmur. Okay. So these are the common signs that you can write. Yes, you can also comment on the JVP. What else is there? You can also comment on the pulse here, right? High pulse, low pulse, specific pulse characteristic. Like in an AR, you see something known as collapsing pulse, right? Tachycardia, very good. Heart rate increases, tachycardia, or heart rate decreases in bradyarrhythmias, right? That's what you need to remember about the signs, increasing or decreasing above the heart rate. Okay. Anything else that we can add if somebody wants to add to this list? Clinical presentation, symptoms and signs. Whatever the specific things that you find, if you know, you write, or else just this much would be enough in clinical presentation. Did we say edema, murmurs, heart rate? Either it can decrease or increase. So based on the arrhythmias, they have tachyarrhythmias and bradyarrhythmias. Then JVP. Comment on the JVP if you know. Then the pulse characteristic, any specific pulse. Like in AFib, we have irregular pulse. In your AR, aortic regurgitation, collapsing pulse. So that comment on that specific pulse. Okay. Now let's talk about the diagnostic criteria. In the diagnosis, you always start in this order. So first thing will be the ECG. It's not the labs, people, it's the ECG that you take in the CVS case. Okay, ECG. ECG should be written first. Then talk about specific investigations, like you have lab investigations like your troponins for MI. Okay. Then for infective endocarditis, you do blood cultures. Then talk about radiological investigations like chest X-ray. And then always, this is a common line for any cardiovascular pathology. We have echo. Cardiography is used for confirmation. Echo is used for confirmation. Okay. Then your diagnosis is incomplete if you don't talk about any criterias, any specific criterias. So what specific criterias we have? Jones criteria we studied now in pediatrics for your ARF, acute rheumatic fever. That is modified Jones criteria. In the same way, we also have modified Duke's criteria. Modified Duke's criteria for your infective endocarditis. So what if you know some criteria, Kanam, you mention that. Okay, so this is the diagnostic criteria. Your diagnosis is incomplete if you don't comment on this. Then the common treatment. So let's talk about the common treatment. What can you write this under the two headings? So number one, the pharmacological management, that is drugs. Then surgical management. Before that, any lifestyle. After that, only the lifestyle changes. Okay. So pehle drugs here. What are the drugs that I can use? Just tell me the classes of drugs. Cardiovascular system में people. Pharmacology, classes of drugs. Yes, we have beta blockers. We have what will you give for edema? Edema. Diuretics, very good. Diuretics. You can also have calcium channel blockers here. What else? For hypertension or for cardiac remodeling, we have ACE inhibitors or ARBs. They come under same category. What else? Drugs, people. Drugs. Cardiovascular. Digoxin we are not using nowadays. Digoxin. The only indication of digoxin was your VFib, but nowadays that VFib is also being taken care of with your lidocaine. ACE inhibitors and ARBs. People, do not forget about antibiotics, because for your infective endocarditis you give your rheumatic fever also. That is antibiotics. What else? Surgery, surgical interventions. What two things could happen here. Two things. So if I'm talking about the valves, okay, either I can repair the valve or I can replace the valve. Okay. Either I can repair the valve or replace the valve. That's what you write here. In any case, if they ask MR, MS, TR, TS, AR, AS, anything, you just mention either you can repair or replace. And what is more beneficial? Repair is always more important than replacement. Okay. The anti-arrhythmics drugs. We'll talk about this. Anti-arrhythmics. So amiodarone comes to a class of drugs known as anti-arrhythmics. Anti-arrhythmics. Okay. The surgery may valve की surgeries can be of these two types. So either you repair the valve, that is more important than replace the valve. Then if you're talking about MIs may you need what? You need to remove the blocks, right? So how can I remove the block? What is the procedure known as percutaneous coronary intervention? Coronary intervention, right? Your PCI, percutaneous coronary intervention, or if it is very late, or if there is a large segment, you can also do CABG procedure, coronary artery bypass graft. Or we have, what is that for bradyarrhythmias? What kind of surgeries do we have? Pacemaker insertions. Pacemaker insertions. So these are some of the examples for the surgeries. What about the lifestyle? The normal things that you write in the lifestyle map. All of the risk factors that we just talked about, especially your modifiable risk factors, you ask them to modify that. So what did we talk about in your modifiable risk factors? Avoid smoking, okay? Don't consume high lipid diet. So then you mentioned one, two examples of the lipid diet. Then about diabetes ka complete lifestyle, we talk no everything. So even the obesity ka, that we talked about, the management, aerobic exercise for 30 minutes, 5 days per week. That's about obesity care management. And hypertension, we ask them to take medications properly. So in this way, you can write at least, if not 1.5 page for this treatment. Then you can mention ECG ka. ECG mein, what will you write under ECG, people? Any specific finding that you know. If you don't know specific findings, or I give you a trick, just go and draw one ECG and come. You don't know how to draw an ECG, normal ECG. Say normal ECG will have a baseline, and this is a baseline. And now first positivity, that is P wave, will come. Okay, this is the first positivity. Then what? Then we have this complex. We don't know what is happening here. The complex, it went down, it went up, then again it went down, then it came back. So this, what is this complex? This is QRS complex. Okay, what is happening here? This is represents your ventricle depolarization. Okay, now the ventricle contraction occurs, and after that, joint repolarization, that is replaced by another this positive wave, this is known as P wave. So this is the normal ECG thing. Okay. So P, QRS, and T. This is normal ECG. P wave, QRS, and T wave. So we have this P wave, QRS complex, and we have the P wave. Remember, normal ECG. Normal ECG. We'll talk about what is happening in each, but remember at least this much. ECG, specific findings have to be mentioned. If you don't know, just draw ECG and come. This was in total about your cardiovascular system. And what are the common complications? Let's write that also, the complications. Common complications in the cardiovascular system. What will you write here as a complications? People, tell me complications. Yeah, so you see, if my heart is not pumping, what can happen? If my left heart is not pumping, what will happen? The pulmonary veins were bringing the blood. Now, what will happen if my left heart is not pumping? If my left heart is not pumping, there will be back pressure. There will be back pressure, and the lungs now contains a lot of fluid. That is known as pulmonary edema. So this is how I detect the left heart failure. Pulmonary edema and hemoptysis will happen because of this. Okay. So this is how I detect pulmonary edema, the left heart failure. What about your right heart failure? If my right heart is not pumping, what can I have? I can have back pressure into the superior vena cava, that is known as your JVP. So increased JVP can be there, or I can have back pressure in the inferior vena cava, and this inferior vena cava will be where it will cause my hepatomegaly, or it can further down, it can cause iliac vein congestion and all, causing edema of the lower limb. And this is how I know my right heart is not pumping. Okay, so complications may remember we have heart failures. So heart failures mean what type of heart failure? So right heart failure or left heart failure. So that's what we talked about. Your right heart failure mean what will you see? You will see hepatomegaly. You see increased JVP. You see edema. Right? So you see edema of the limbs. Edema of the limbs. That's what you see. What about your left heart failure? Left heart failure mean you see pulmonary edema. Pulmonary edema. Okay. So that is about that. Anything other than this heart failure one thing. So complications can be of any specific complications, can I say cardiogenic shock also? Heart is not pumping, cardiogenic shock. What else? Any specific complications of your arrhythmias, especially your AFib. AFib is basically your atria ka pharparana. So that is fibrillation. Fibrillation is that. So what can it lead to? It can lead to a lot of thromboembolism, which can throw a lot of microthrombi. This thromboembolism can block my cerebral circulation, causing stroke. It can block my GIT, causing mesenteric ischemias, right? So it can also block my coronary circulation, causing MI. Okay, so these are the complications associated, common complications. Okay, people, followed. How many of you followed the template? Pericardial effusion, pulmonary arterial hypertension. Yes, that's what it is basically. PAH. Okay, pericardial effusion. It can also cause heart failure. What else? Did we miss something? Does somebody wants to add any point here? Everybody followed, right? The common template. You just need to know first which is, what is what. This is the basic anatomy. So tricuspid on the right side, mitral on the left side. You can draw this diagram also in exam. Okay, the common diagram, a rough wala diagram. Followed, everyone? Any doubts in the template? No? Okay. See, we will not talk about acute rheumatic fever because we have already done this in pediatrics. So directly we will start with a few templates. So we have hypertension ka case. Can somebody tell me the diagnosis? Everybody will tell you it's a hypertension case, right? So this BP is more than 140 by 90. 52-year-old man walks into a clinic for a routine checkup. No complaints. BP is more. So how much more than 140 by 90? Classically, it is a hypertension case. But that's not the question here. The question is, what single finding makes this an emergency? That's the question. What single finding will make this an emergency? No complaints. The fundus shows blurred disc margin. That's what you need to remember. And if the fundus shows blurred disc margin, what is this case? This is what? Apple edema. And this is people malignant hypertension, how it presents. End organ damage. End organ damage. Let's talk about hypertension now. Now, in the intro other part of hypertension, what will you write here? You mention what is hypertension. You mention it is chronic elevation. Chronic elevation of your BP. Chronic elevation of blood pressure. And which blood pressure? Venous or arterial? Arterial blood pressure. So how can you define this? So I have elevated blood pressure in the systolic phase and also in the diastolic phase. So I will write the two cutoffs. So SBP cutoff and DBP cutoff. More than or equal to 140, more than 90. Okay, so that you can remember, or you can also write more than 140 by 90 mm of mercury. So that's the definition. More than 140 by 90 mm of mercury. Now, we have two categories, two causes for this hypertension. So hypertension can come itself as a primary issue, or it can be due to some secondary causes. Primary hypertension is known as your essential hypertension. Essential hypertension. We don't know the cause. No identifiable cause. So what they write here, they write ki some genetic factors will be there or some environmental factors will be there. What are the genetic factors? What are the environmental factors? So genetic factors, may they say we have this blood vessel, and this blood vessel is innervated by a lot of nerves, and these nerves will keep what? Your sympathetic nerves keeps the blood vessel in a vasoconstricting state. So these genetic factors may they mention if I have polymorphism in the genes which were regulating this vasomotor tone, then I can get hypertension. The genes regulating vasomotor tone, then I can get hypertension. Okay. What are the other reasons? The other reasons could be, the kidneys. So the kidneys, in few people, what do kidneys do? They don't remove sodium. Okay. Decrease the sodium excretion by genetics. Some gland issue, some channel issue will be there. They decrease the sodium excretion. So if sodium is excreted, meaning a lot of sodium is retained, obviously BP will increases. Take more fluid volume, more cardiac output, more BP. So that's how you remember the renal value mechanisms. Or there are some environmental factors. So environmental factors may I am hypertensive because I am obese, or I consume smoking. Then I don't do any activity, sedentary lifestyle that is putting onto my weight. Or my culture allows me to have a lot of salt, not just the common salt, a lot of salt, high salt intake. This. Sorry for the disturbance, people. We are back online. So we were talking about environmental causes of hypertension. So we have this high salt intake, and all of this will cause what? Your primary. It's not the secondary, people. So high salt comes under primary hypertension. Primary hypertension. That's what you need to know. Primary hypertension. Who will tell me the secondary causes of hypertension? Secondary causes. Yes, people. Secondary causes of hypertension. Can you tell me at least two causes? Yes, Cushing's. Cushing's. What else do I have as a secondary cause? Okay, if you're talking about renal system, so in the renal may at least tell me two stuff, very, very important. So once you mention the renal artery stenosis, what else that I taught you? Yeah, pheochromocytoma, very good. That is also a renal adrenal one issue. What else do we have? Can I write polycystic kidney disease, PCKD? Polycystic kidney disease also will cause a lot of EPO. That will be, this renal causes of hypertension. Can you tell me a drug that can cause hypertension? Drugs, drugs, man. If I say Cushing's here, can I write steroid also here? Right? What else? All of your sympathomimetics like phenylephrine can cause hypertension. Somebody has anything to add? Can I also write your ARF or CRD, CKD? They can also cause hypertension. Hypertension will be seen ARF and CKD. Okay. Cirrhosis. How can cirrhosis cause hypertension? Okay. So some of the secondary causes that you can mention of hypertension. Okay. What else? Now let's talk about pathogenesis. What is happening in hypertension basically is, there is two things. Either volume, there is lot of volume, blood volume, or there is lot of vascular resistance. Okay. Vascular resistance, and hence there is an increased BP. Hypervolemia with hypovascular resistance. So we meaning what? So if this is the blood vessel is getting abnormally narrow. So that's the vascular resistance. And that's how, the narrow blood vessel, vasoconstricted blood vessel will have to do a lot of work. And that's why blood pressure increases. Yeah. Okay. So kidneys fail to excrete sodium properly. Sodium excretion doesn't happen. If sodium excretion doesn't happen, then we have a lot of hypovolemia. What else could be the reason? Your RAS getting activated in your renal issues. So RAS activity and sympathetic overactivity can cause a lot of hypovolemia and also a lot of vascular resistance. Okay. Sympathetic hyperactivity. What else do I have? Because of this progressive changes, because of these changes, there is ultimately vascular remodeling, meaning my vessels normally should be like this, but because of these chronic changes, the vessels are remodeled into always vasoconstricted statement. Okay, so vascular remodeling is what you notice under this pathogenesis. The ultimate result here is the vascular remodeling, and that's why the clinical presentation will be seen. What are the symptoms? Symptoms, people. Now let's talk about symptoms, then we'll talk about signs. Symptoms. What will you write under symptoms? Hypertension. Palpitations. How many of you say palpitations? How many of you say breathlessness? Headache? The first symptom that we write here is asymptomatic. Most common is asymptomatic, okay? Because they are asymptomatic. Then whatever the symptoms will come, that only comes after damaging the organ. Okay, if they complain of headache, meaning there is a damage that happened, it's a late feature. If they complain of your dyspnea, meaning that dyspnea is because of your LVH, left ventricle hypertrophy, that has happened. Left ventricle hypertrophy has happened. Okay. If they complain of any angina, that indicates that plaque has formed already. Okay. So that's an end result. Okay. So that is atherosclerosis. All of these are the symptoms. What are the symptoms of malignant hypertension? You will tell me malignant hypertension. What is malignant hypertension? Everything will become severe. And remember, you have severe headache here. And with headache, also do not forget to add on the vision issues. Okay, so you have vision issues. So vision problems. ठीक है, धुंधला धुंधला दिखाई देना, vision problem, patient will come and tell you altered sensorium sometimes. Okay, then we have heart failure issues, renal failure issues, blurring of visions, everything. Okay, so that is malignant hypertension. What about the signs here? Signs myth. What will you notice? So what do we have? First, the blood pressure. More than or equal to 140 by 90, that's one sign. What will you notice? If you auscultate the patient, I have two heart sounds. I have S1, I have S2. So S2 may, what is happening? Aortamic pressure is increasing. So S2 has two components. It can be your aorta or it can be your pulmonary artery. So A2 and P2. In this, remember, loud A2 will be there. Loud A2 is characteristic of your hypertension. Always, your signs are incomplete in hypertension wala answer if you don't comment on the fundoscopy. Okay, fundoscopy pe comment always you have to do. Fundoscopy, do not miss this. What are you detecting here? You are ruling out hypertensive retinopathies. So how can you detect that hypertensive retinopathies? If you detect papil edema here, directly classify it as malignant hypertension. Papillary edema, if you are detecting directly malignant hypertension. Hypertensive retinopathy के gradings are there. So from grade 1 to grade 4. You can thinking if it is there or not. So that's how you can grade hypertensive retinopathy ka. Okay. Then any clue to the secondary causes. That also you can write under the signs. Any clue to secondary causes. So what are the clues for secondary causes? You will see Cushingoid features, right? Cushingoid features if in Cushing disease or if the boy or the patient is on steroids. So any clue to that? If you detect renal artery stenosis, there will be abdominal bruise. So that sound will come. So these are some of the clues. So all of this will come under the signs or the category. What will you write under the diagnosis? It is a clinical diagnosis which can be made only with BP measurement. But remember, you have to measure BP in two settings. So two settings before labeling it as a hypertensive. Okay. Fundus examination is compulsory here. And what are you looking for? You look for end organ damages. End organ damage. Okay. This is important. Look for end organ damage. Now, treatment mein, what is your main intention? What is your main intention in treatment? The same treatment you can write, but here you start with the lifestyle. First, start with the lifestyle modifications. What will you mention here? Salt restriction, complete restriction of the salt. How much they should take? Less than 1 gram. Your DASH diet, mention about that. DASH diet. Okay. Then exercise. All of the exercises, everything. What about your habits? No smoking, right? No alcohol. All of the risk factors that we talked about, you do that, you talk about that. Then, any drugs that I can give for hypertension, any drugs. We have so many drugs like your beta blockers, we have ACE inhibitors, we have your ARBs, we have calcium channel blockers. Let's do that. Let's do the drugs here. We can be right. So let's talk about the drugs here. So who will tell me beta blockers? Beta blocker wali drugs. Tell me one beta blocker. One beta blocker. All the lols. Achha, tell me one drug which has a lol key ending, but it's not a beta blocker. Can somebody tell me that? So yes, you are right. Most of the beta blockers they end with lol, but not all. We have two categories. I can block both beta 1 and beta 2, that is non-selective beta blockers, or selectively I can block only beta 1. Okay. So beta 1. So meaning it is only on the heart. So I have one heart, beta 1 is on the heart. So what are they? So you can remember we have metoprolol, atenolol, esmolol. Esmolol. So I use this when I need only on the heart action. But hypertension, what do I need? I need either with metoprolol or we can also have non-selective wala action. Non-selective wale mein I have two categories. I have sympathomimetic action wale drugs with intrinsic sympathetic activity ISA wale, without no ISA wale, without intrinsic sympathetic activity, or with also additional alpha blocking ability. So three agents are there. With intrinsic sympathetic activity means they will not cause orthostatic hypotension. Okay, so that's the benefit here with intrinsic sympathetic activity में. So the only drug here is pindolol. No intrinsic sympathetic activity means what? No intrinsic sympathetic means they have a lot of this orthostatic hypotension, propranolol here, propranolol actually, it's propranolol. Then we have timolol, beta blockers, alpha blocking ability. It is also beta blocker plus alpha blocker. That's why we use it even in pregnancy. Labetalol, labetalol, okay, labetalol, very important. Labetalol 100 mg given twice daily in pregnancy. Beta blockers. Now, somebody tell me about your ACE inhibitors. You will tell me ACE inhibitors. Carvedilol. Carvedilol, yes, you can write carvedilol also. But tell me one drug which ends with lol, but it's not a beta blocker. So don't sleep, I'll tell you. I'll tell you today. Don't sleep till then. If you don't sleep, I'll tell you. What are ACE inhibitors? ACE inhibitors. So ACE inhibitors basically do they act where. So first for that you need to understand the RAS. So whenever there is decrease in GFR, who will the kidney send as a convoy? The kidney will send from the renal system. We have the juxtaglomerular cells. They will release the convoy. That is the convoy is a renin. Renin is the convoy, and the renin where it will go? It will go into the liver, and in this liver it will activate one thing. What is that thing? The angiotensinogen. So we have angiotensinogen ka activation. So angiotensinogen will be converted by this convoy into something known as, this renin will do, and it will convert into angiotensin 1. This angiotensin 1 will come out of the liver now and will roam. Where it will go? It will go to the lungs. And in the lungs, this gets converted into your angiotensin 2. And this angiotensin 2 is a powerful vasoconstrictor. Why it is powerful vasoconstrictor? Because it can itself act as a vasoconstrictor. It can even increase your aldosterone के levels, increases sodium का reabsorption. ठीक है, thereby increases sodium reabsorption, thereby causing what? Hypervolemia. ठीक है, it can also act on the brain osmoreceptor, causing increase in ADH का release, thereby itself causing water का increase, thereby causing hypervolemia. Or it can itself act in the it can cross blood-brain barrier, acting on the thirst centers, increases water intake, increases hypervolemia. So it's a powerful vasoconstrictor. Which was the agent? Here it was ACE enzyme. So now what did we do? Now we blocked this enzyme. So ACE inhibitors work at this level. So they block this. So that's what you need to know about ACE inhibitors. And all of them, they ends with pril. They ends with pril. So remember at least two or three. So we have captopril, we have enalapril. Enalapril, captopril is the classic one drug, the prototype drug in this category. Then enalapril, lisinopril will be there. Lisinoprils. Okay. Then if you want to remember, you can also remember your ramipril. You must have pharmacy knowledge. Captopril, lamipril. It's not timolol. Not timolol. It's not. Okay. I'll tell you. So what do you need to remember about the ACE inhibitors? Now, we did not continue this drug because it had many side effects. We did not know when we blocked it, but after that it gave a lot of complications with ACE inhibitors, and you can remember with this prototype name captopril. So what are the complications with ACE inhibitors? Complications name, what are the captopril? So C stands for your cough. It was causing cough. That too a dry cough. And with A stands for angioedema. Angioedema. Okay, angioedema was there. What else? It was leading to your P for proteinuria. Proteinuria. Okay, very important. Proteinuria as a side effect. Then P was teratogenic. It was teratogenic. Cannot be given to the pregnancy lady because it was causing growth retardation in fetus. Okay, teratogenic. T. What was O stands for? O matlab you remember it is neutropenia. 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 Decreasing the nitric water level. Then what else? Pril, captopril. So another O was for hypotension, right? So why P for neutropenia, right? Okay. So this is neutropenia. So we have this P for neutropenia and this hypotension. So all of these were the side effects. So that's why they are being withdrawn. What are we doing now? We are blocking the receptors. The angiotensin receptors blockers we use. So at this level we block, that is ARBs. angiotensin receptor blockers, and all of them they end with what? All of them they end with sartans. So now telmisartan, very classic. Telmisartan, losartan, telmisartan. They are the example of your ARBs, right? So ACE inhibitors. Followed people ACE inhibitors. ACE inhibitors, very important. The examples and the classifications. Now, who will tell me calcium channel blockers? Calcium channel blockers, people. CCBs. How many types of CCBs do we have? CCBs. We have only two types. As far as clinical scenario is concerned, remember we have two types. We have DHPs, we have non-DHPs. Okay. DHPs and non-DHPs, as simple as that. So DHPs are the drugs that act on the ducts. Okay. D for ducts here. So what are the ducts organs? The agents here depends. All of your depends will be there here. Nifedipine, amlodipine, they are the examples. So nifedipine, 5 mg, amlo 5 mg, amlodipine 5 mg. So you can remember with this 5 mg. So nifedipine, amlodipine, there comes under this dipine category, and they act on the ducts. So ducts, remember the blood vessels. So the blood vessels, they are specific to blood vessels. Okay, they cause vasodilations of the blood vessels, and this is what I prescribe for hypertension, right? Hypertension, what is happening in the blood vessels, right? So I can prescribe them in hypertension. Whereas your non-DHP solid agents, non-DHPs, remember two non-DHPs. So we have this verapamil and diltiazem. Non-DHPs, they act on heart. Those two, remember this. Verapamil and diltiazem. Verapamil, diltiazem. Dil, so naam mein hai na, diltiazem. It acts on the heart. But remember, it's a non-DHPs. So non-DHPs means, what is DHP? Dihydropyridines. Non-DHPs, non-dihydropyridines. As simple as that. So remember, in this category, you will not forget. Diltiazem, verapamil. Followed the dose you want. Verapamil ka 40 mg. Diltiazem ka 30 mg. Okay, so this is about the doses. Follow, how many of you follow? Please raise your hands. The three types. Calcium CCBs. Yeah, we have CCBs. We have beta blockers. We have this ACE inhibitors. So in hypertension ke management mein, write all of these drugs. Beta blockers, ACE inhibitors, CCBs, ARBs. Everything you have to write. Hypertension ke management. Just write it. You don't need to know whether you give or not. You just mention you give this. Okay, hypertension ke management mein. What else can you write in the management wala part? Remember, as far as your malignant hypertension, if you detect, if someone with a papilledema wala thing, okay, malignant hypertension mein, you have to admit in ICU. Admission is required, and in that, what is your goal? Immediate BP reduction with IV drugs. IV drugs. IV drugs, the most common that we use is labetalol. 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 Okay, very important. Malignant hypertension can management में. What am I afraid of here? I'm afraid of so many complications. Let's start with your cardiovascular system. I'm afraid that my heart is pumping a lot, especially who will push the blood into the left, into the systemic aorta. The left ventricle, right? The left ventricle will push, and left ventricle, if it does a lot of work, then hypertrophy will happen. Okay, so that's what I'm afraid of. If my vessels get narrowed, then I can also get the MI, that is coronary artery disease. Okay, that's what. If the aorta gets narrowed, aortic dissection can also happen. So these are the cardiovascular system that I'm afraid of. But ultimately, heart failure ka thing. Okay. What about CNS? CNS, if there is a vessel narrowing in the CNS, then I can develop strokes, right? If my fragile capillaries in the in CNS, what will happen if there is hypertension? I can have this lacunar bleed. What is that known as? Lacunar bleed, the hemorrhagic stroke. Okay, hemorrhagic strokes. So lacunar strokes, your micro bleeds, we'll talk about in CNS. Hemorrhagic strokes can be there because of this. Okay, even subarachnoid hemorrhage can come. Your intracranial hemorrhages can come in CNS. What about the renal? So basically, we are talking about the end organ damage. So you'll also write the first proteinuria, hypertensive nephropathy. The first thing is proteinuria. Then it can go into a prolonged state known as chronic kidney disease. In eyes, what am I afraid of? Eyes, retinopathies. Hypertensive, your retinal arteries, retinopathies, right? Then if papil edema is there, then that classically indicates malignant hypertension. Okay, people, so this is about hypertension. Followed, how many of you followed? Please raise your hands. Now you know how to start. And the first, which of the first drug that you start for a hypertensive case? Start with ARBs. They are safer. Okay. ARBs are safer and they also give protection to what? They give protection to your renal valley system. Okay. They give protection to the CVS also. The morbidities and mortalities of CVS and renal, they are decreased with ARBs. So that's what is hypertension. If you need a quickly path, basically hypertension is arterial BP elevation. SBP and DBP more than 140 by 90. Okay, we talked about primary and secondary causes. And we also talked about your hypervolemia and hypervascular resistance, how it happens. There are three agents here. Okay, sodium excretion, RAS, and sympathetic activity that is getting increased. And that's why what is happening, ultimately the vascular remodeling. The normal vessel, it should be like this, but vascular remodeling, meaning now the vessel is constricted. Remodeling occurs here. Okay, so this is the clinical presentation in which talk about symptoms. Most common symptom is asymptomatic. That's what you need to know. Okay, this is a favorite Viva question. Favorite Viva question. Asymptomatic is the most common. Okay, what else? The malignant hypertension, headache, vision issues, blurred vision. You have this altered sensorium and heart failure by stage. In science, your signs are incomplete if you don't talk about fundoscopy. Fundoscopy is important. Also mention loud A2 will be there. Okay, what else do I have for clues to secondary causes? So diagnosis, maybe mentioned everything. Treatment, you are all of the drugs. So beta blockers you can elaborate, ACE inhibitors you can elaborate. So you can easily write treatment under 3 pages will come. For the treatment will apart. The first half page will be this. Then the half page will talk about beta blockers. Then this will take 2 pages. Sorry, 1 page, half page, and half page. If you talk a lot of flow chart with the RAS system that I just talked about, then also comment on the malignant hypertension. This should take 3 pages. Okay, as simple as that. Then about the complications all apart. Complications you can write under 1 page. Just the complications here, the CVS, CNS, and organ damages are happening here. That's what you need to know about these complications. Followed everyone? You can also write diuretics, but not needed. Not we don't usually give diuretics, but you can also mention diuretics under the drug wala category. Okay. So let's talk about another case. So what did we have? The case mein Founder showed blurred disk margin, so it is malignant hypertension. It's not essential hypertension, it is malignant hypertension. That's what you need to know about this. Then we have this case. Can you tell me the diagnosis? Yes, people, can somebody tell me the diagnosis here? Okay, we have this smoker clutches his chest with a fist while walking uphill. Pain lasts 7 minutes, radiates to the left arm, and disappears with rest. So people, this should make you think of this is not MI. MI ka pain will be there always until you give morphine to the patient. So this, since it is disappearing, it is angina. Okay, it is angina. What will you see here? So this is the normal ECG. This is a patient with angina. This is an ECG of a patient with angina. Okay, what is angina? So here you see basically chest pain, but this chest pain can radiate up till the neck and also towards both of your limbs. Left is more than the right. That's what you need to know. Followed everyone? What are we talking about? Angina. Let's talk about angina here firstly. So what do we have in angina? You will start your definition with this. It is a chest discomfort. It is a chest discomfort due to what? It's not due to the infarction. It's due to myocardial ka ischemia. See, there is a difference. Due to ischemia, due to myocardial ischemia. Chest discomfort due to myocardial ischemia without, that's the complete definition, without myocardial death, without myocardial cell death. That's what you need to know about this angina. Meaning there is a block in the capillary, but the block is not complete. It's only a partial block. Because of this partial block, I have a decreased blood supply. So decreased blood supply is known as ischemia. It's not the death that is happening. It's the only, what do we say? The block, the partial block. So it is myocardial ischemia without myocardial cell death, and this comes under category of coronary artery disease. Most common presenting symptom of coronary artery disease is angina. Angina. Okay, so let's talk about angina. Why it happens? Angina, chest pain. It happens mainly because of coronary artery disease. The coronary arteries, they are being blocked by this fibrofatty plaque that is known as due to atherosclerosis. Atherosclerosis. So you mentioned all of that, the risk factors for this, the modifiable and the non-modifiable risk factor that we discussed today about this. Okay, but angina can also occur. If there is no block, then also angina can occur. If the coronary artery gets constricted, it gets constricted, then also the block can occur, and this is known as coronary vasospasm. And here, you remember, this is known as the angina that happens due to coronary vasospasm is known as Prince metal angina. Prince metal angina. That's what you need to know. Prince metal angina. So whenever angina occurs, there will always be a reason for this. The reason, the triggering factors will be increased oxygen demand, increase the load on the heart. When it will happens when you do exercise, when you climb up stairs. Okay. So that is basically an increased load on the heart. So or in the emotional stress. So all of them can trigger angina. Even fever or a fever-like state like thyrotoxicosis can trigger angina. Myocardial oxygen demand increases because of these triggers, and that's how they trigger. Like so this cell, so if it is a cell here at the end, and it will need a lot of oxygen, but this block, the partial block, doesn't allow the cell to receive that oxygen. That's how angina occurs. Angina pectoris, the chest pain. Okay, the pathogenesis here is what? There is more oxygen demand, but less supply. That's what you need to remember under pathogenesis. Why it is less supply? Because why it is less supply? Because of the block. So here, because of the block, there is myocardial ischemia, but not myocardial infarction. So it is a reversible ischemia. Reversible ischemia is what you need to remember under the pathogenesis. No cell death. As in no cell death, will the enzyme be elevated? Will the troponin will be elevated? So no increase in cardiac enzymes. That's what you need to know. No increase in cardiac enzymes. How will the patient present in the clinical presentation? They will come and tell you chest pain, but they'll tell you characteristic features of this chest pain. So they'll tell it happens in, it builds up. Chest pain builds up, they'll say. It doesn't happen suddenly. It's not a sudden thing. It builds up over 1 minute. So over 30 seconds to 1 minute, they say. So that's how the pain builds up, and it remain for around 5 to 15 minutes. And very, very important, they will tell you the relieved chest pain is relieved with rest, or when they take your sublingual nitrate. So when they take this sublingual nitrate, the chest pain is relieved. What will the rest may decreases the oxygen demand. And what will nitrates do? Nitrates basically dilate the vessels. Dilate the vessels. So that's how they relieve the chest pain. What else do I need to know about this pain? Where it happens? Most likely mid-sternal. Mid-sternal it happens, and it can radiate up to the neck, up to the left arm, and also to left shoulder. So everything on the left side. Okay, mid-sternal it starts. Very, very important, the patient clenching of the fist over chest. So in this clinical scenario, what is this sign known as? Levine's sign of angina. Clenching of chest with the fist is known as fist. That is Levine's sign. Okay, so this is not MI, people. This is just Levine's sign. Okay, what else do I have? I can also have associated symptoms of autonomic hyperactivity. Sympathetic system. What are the associated symptoms if sympathetic will get activated? We have sweating, right? We have palpitations. That's basically your autonomic systems getting activated. Any specific signs that somebody can tell me? Any signs? What can I write under signs? Signs, may people. Signs of angina. Can I write this signs may sweating with during attack basically? What else? What else? Angina के signs में. Can I also see signs of atherosclerosis? How many of you are not sleeping? Please raise your hands. Signs of atherosclerosis, because angina is basically atherosclerosis. What are the signs of atherosclerosis? I have lipid deposition on the tendons. So tendon xanthomas. What else? I have lipid deposition on the cornea, corneal arcus. I have lipid deposition on my skin, xanthallus mass. So all of these are the signs of atherosclerosis. Very, very important. Or if you can try to detect the peripheral pulses now, peripheral pulses will be absent. Absence of peripheral pulse, especially, they will come with peripheral vascular diseases. They also indicate your atherosclerosis. So this is what you find here, atherosclerosis में. And sometimes during the attack on auscultation, you can also see third heart sounds. So S3 gallop will be there. Why S3 gallop? Basically indicates increased metabolic demand, increased oxygen demand to the heart. Myocardial oxygen demand increases. Okay, followed everyone. This is about angina. Angina ke presentation. What will you write? Chest pain, you elaborate. Then you talk about associated things. Then talk about the signs. Signs may during the attack, what happens, and signs of atherosclerosis. How can I diagnose angina? I need to prove two things now. First, I need to take an ECG. And in that ECG, what will I look for? I look for ST ka depression. Okay. HT depression. What is happening here? So if I talk about, take a section of this myocardial tissue, what I notice here is, if the blood vessel is supplying here, then I have only subendocardium which is getting affected here. Only, it's not a transmural thing. Okay, if transmural means total vessel ka thickness, total wall ka thickness is transmural. If it gets affected, I will see ST elevation, and that's seen in MI. ST elevation is MI, but here there is no ST elevation. Only the subendocardial part is affected, and that's why I see ST depression in ECG. ST depression with T wave inversion. This is classical finding in ECG. That's what you see here in this case. What did we have? We have, this is, just label this. This is P wave, Q, R, S, and T. So in the normal, you see, this is also P, Q, R, S, and T. So see, this ST wala jo segment tha, this length, this line was isoelectric line, meaning it is at the level of the isoelectric line. But as you see in this case, you see, so this is the isoelectric line. So ST should have been here. It is below that line, meaning depression. ST ka depression has happened. ST depression. Okay. Angina, ST depression with T wave. T wave inversions are not classically seen. So this ST depression, you remember, ST depression for this ECG wala finding. What I can do here is, if ST depression is not seen, I can do an exercise. So during exercise, if I take the ECG, I will also see the same things, because angina will disappear with rest. Okay, so exercise ECG or resting ECG that I can take, or I can directly detect the partial blocks. So do I have a test to detect the partial blocks? I have. So what is the name here? Cardiac scintigraphy. Scintigraphy. So basically, it's an angiography where you detect the perfusion defects during the stress. Or I can also do an echo here. In echo, what am I noticing? I'm noticing any regional wall, in any regional wall. Okay. So that's what you notice. Any regional wall, motion abnormalities. Motion abnormalities is what you notice. What is gold standard here? Coronary angiography is gold standard. Coronary angiography में each of the coronary artery you do, and directly, you can do the diagnosis there itself and the treatment also there itself, done before revascularization procedures. What is about the treatment? We'll talk about treatment. You see, coronary artery disease is a gold standard here, gold standard therapy for your angina diagnosis. Now, how can I treat angina? You can write about all of the lifestyle measurements that we talked about. And apart from that, what are the drugs to treat? So I need to give what? I need to give vasodilators, which will work best. We have nitrates. And why nitrate? Because this is the only one that can be given sublingually. Sublingually. So sublingually means within 5 minutes I have the onset. So an example for this will be glyceryl trinitrate. You have isosorbide dinitrate. So these are the examples for nitrate for the drugs. Okay, so nitrates are given classically in angina. And apart from that, I also need to, since the plaque is already formed, I need to stop it from becoming a full-fledged thrombus. How can I stop it? So I have to give anticoagulants. So which anticoagulants? Especially your antiplatelets. Antiplatelets are indicated here. So we have aspirin or clopidogrel. Clopidogrel. So that's what you need to know. Clopidogrel. Clopidogrel is an irreversible platelet blocker. Aspirin is also a platelet blocker, thromboxane A2 inhibitor. Then The third chuck is I need to decrease the load on the heart. Okay, decrease the myocardial oxygen load. For this, I have beta blocker. So which beta blockers now? Cardioselective or non-cardioselective? Mostly cardioselective. Mostly cardioselective. Okay, so that's what you do here. Mostly cardioselective beta blockers. Okay, so where I should not give beta blockers. So contraindications of